This morning, our plenary feature speaker is Dr. Jonathan Beam, and followed by our local plenary speaker, Marla Beauchamp. There is a relationship between Jonathan and Marla. Marla was Jonathan's postdoctoral fellow at Harvard, so that's the connection, and we're delighted to have Jonathan here, and we had wonderful conversations and meals last night as well. Jonathan is the director of New England Geriatric Research Education and Clinical Center at VA Boston Healthcare System, the first physiologist to be appointed director of VA Geriatric Research Education and Clinical Center. He's a professor in the Department of Physical Medicine and Rehabilitation at Harvard Medical School and a staff member at Spaulding Rehabilitation Hospital. Dr. Bean is an internationally recognized expert in geriatric rehabilitative care, having extensive experience in the conduct of clinical trials and measurement of disablement outcomes. With advancing training in exercise physiology and epidemiology, his work has focused on mobility problems as a marker of adverse health outcomes among older adults. He addresses both risk factor reduction and the development of clinically feasible prevention strategies. Dr. Bean has strong commitment to the mentorship of trainees in geriatric rehabilitative research, having been awarded a mid-career investigator award from the National Institutes of Health. Welcome, Jonathan. And I will just introduce Marla, and then we can have you come to the podium. Marla Beauchamp, who is a physical therapist and assistant professor, soon to be associate starting July 1. In the School of Rehabilitation Science and Department of Medicine at McMaster University. She holds a Tier 2 Canada Research Chair in Mobility, Aging, and Chronic Disease, and an Early Researcher Award from the Ontario Ministry of Colleges and Universities in Technology and Aging. Dr. Beauchamp's research program is focused on developing evidence-based strategies to improve mobility among older adults and those with chronic diseases. Her ongoing research includes a multi-site longitudinal cohort study on long-term outcomes after COVID-19. Welcome both to Jonathan and Marla. Jonathan, podium is yours.
So, what I'm going to cover today is we're going to talk a bit about screening risk, conceptualizing function as a guide for treatment. I'm going to talk a bit about how we deliver high-quality care, and then the notion of rehabilitation to serve as a model of secondary prevention. And I'm going to be speaking more in general, but I think that as you listen, you'll imagine how this has relevance to these times in terms of dealing with COVID. And I know that Marla will be speaking specifically about her COVID-related work. Also, I want to acknowledge the funding that I have for some of the work I'll be presenting from the Veterans Administration, NIH, and foundations as well. So I'd like you all to take a moment and to imagine yourselves as a primary care physician. So you know that the fastest growing segment of your population, your patient panel, are the oldest members of your patient panel. And the other important fact to recognize is that maintaining functional independence tends to be the #1 priority that older adults seek care from a physician. The other thing that you know is that you are trained in the disease model, so you are trained to sort of think about a single disease, but you know that in older adults, they tend to have multiple chronic conditions, and that makes care more complex and more challenging. And so this is, in the US, we have primary care physicians are mandated to do an annual wellness visit, a visit where they will actually focus on health and prevention, and they'll evaluate a person's risk and develop a secondary prevention plan for that individual. And so one of the things that's really important is being able to assess risk in those patients. Who amongst their panel is at greatest risk for adverse health outcomes? And so, you know, you're moving from one patient to this new room, and you know, your nursing staff has been getting vital signs. And so I'll pose a question to you. Which vital sign that you'll be looking at is the best at predicting the risk for adverse health outcomes for your older patient? You know, is it heart rate? Is it blood pressure? Well, actually, it's the speed with which they walked into the room. Actually, the vital sign that wasn't really measured. And so this is an article from JAMA in 2014, and what it shows is gait speed, but you could put into a composite measure of physical function like the short physical performance battery, which was mentioned yesterday, which is a combination of gait speed, chair stand time, and standing balance. And what you see is that as performance goes from, on the x-axis, from the right to the left is worse, and you see a linear relationship with the adverse health outcomes, which in this case is the prevalence of ADL or mobility-related disability. And it's almost a linear relationship. But the power of these performance tests is the fact that it doesn't matter what outcome you put there. You could put mortality, you could put institutionalization, you could put nursing home admission. You see the same associations. So it's this powerful predictor of adverse health outcomes. And so why is that? How can we conceptualize that? And perhaps the best way to conceive of the role of these performance-based measures is to think of an orchestra. If you think of an orchestra, you think of the sections of the orchestra all working together to produce a beautiful piece of music. On the other hand, if you think of my 4th grade jazz orchestra, and you have the different sections of the orchestra, we didn't sound so good. All the sections weren't really working together, they weren't performing as well as they should, and the resulting piece of music was generous if you called it music. It was a product, let's put it that way. But the metaphor here is the fact that mobility is an integrative task. And if you think of the sections of the orchestra like the body systems in our body working together, they all contribute to our ability to perform mobility skills. And so small incremental deficits that occur in our organ systems as a result of aging, or the impact of specific diseases, or the accumulation of chronic disease, will impact those systems, not so much so that if you look at the system you'll see abnormality, but with an integrative task you actually see deficits. And so it's almost like a canary in the coal mine for what's going on in the person. And so that's why it's a very good integrative measure. Now, another integrative measure for risk that's received a lot of attention is frailty. And I know this was discussed yesterday, and Dr. Rockwood spoke, who's one of the leaders in frailty research. And frailty is generally defined as a state of increased vulnerability to stressors caused by decreased physiologic reserves, much like I've been describing. And it's great at risk stratification, and there's tremendous relevance for all types of care. And it's really based on the geriatric assessment. Geriatricians are trained to evaluate their patients across all the different body systems and to evaluate where there are deficits and then to sort of address those in a comprehensive way. And so it's really just the patient and their deficits. And the two major paradigms are the frailty phenotype, which was developed by Linda Fried, and the frailty index, which was developed by Dr. Rockwood and his group. And so when we think about what's called the Fried phenotype, which is based on the cardiovascular health study, it's a combination of 5 really performance tasks. Weakness by grip strength, slowness generally by gait speed, reduced physical activity, fatigue, and weight loss. In contrast, the frailty index, and I think this was discussed yesterday in some detail, is really the total burden of health deficits or abnormalities that don't saturate with aging. And so you can have 50 of those that you might evaluate, and based on the number of deficits, maybe it's 10, you determine a ratio of 0.2, 10 over 5, and that would be your frailty index. And that can be done, you can use self-report measures or observer-based assessment measures to determine that index. And also, both have been described as being derived from electronic medical records as well. And this is data from looking at some of Dr. Rockwood's work, looking at the probability of survival at the top, the probability of institutionalization, and you see very similar plots as well to when you're measuring frailty and with more severe frailty being, of course, at the bottom levels on these figures. But this was actually developed from a more simplified scale called the clinical frailty scale, where you can look at an individual based on whether they're very fit all the way down to terminally ill, and you can score them between 1 to 9, and you can determine their level of frailty. The elegance of this is that it's simple, and that actually it accounts for cognitive impairment as well. But if you look at it from a rehab perspective, you say, well, they're really kind of measuring physical function, aren't they? And so some of the people in the frailty world have also said that, well, wait a second here, you're sort of conflating disability and frailty at the same time. Now, a lot of my geriatrician colleagues that I work with in our center at the VA, they say, so what? Because at the end of the day, we want to stratify risk. We want to know who's at risk for adverse health outcomes. And so it doesn't really matter as much. On the other hand, and what I'm going to try to illustrate in a little bit is that the rehab perspective may allow us a more nuanced way of looking at how we would treat these patients. So the statement from this article was that if disability is an outcome of choice, then frailty instruments should not contain ADL items, and that there's not sufficient separation of those concepts. On the other hand, again, this is from colleagues at Brigham and Women's Hospital, Dae Kim, who's a geriatrician, and basically saying that if you look at the frailty index above, that's the decimal numbers you see, and you look at the short physical performance battery scores, that the physical performance measure can actually be a crosswalk for a measure of frailty. So there's this overlap between the two concepts that conceptually may be different things, because one's talking about disability and the spectrum of disablement, the other is talking about resilience or vulnerability to stressors, or resilience from stressors, but it may not matter as much. So when you look at frailty measures, you know, the two measures that I mentioned, the frailty phenotype, the frailty index, both can be derived from EMR data and can predict risk across populations. And in particular, the frailty index is shown to be really powerful in that way. And I'll steal a little bit from Marla's talk to say that it's also been shown to predict vulnerability to death and adverse health outcomes in the face of COVID. On the con side is this concept of sort of confusing the concepts a little bit for some, and the fact that it is a bit more of a two-dimensional perspective and doesn't consider the interrelationship between those deficits, between body systems, activities, and participation. And it can be more challenging as a guide for treatment. So let's think a little bit about how we conceptualize rehab, and I want to start with a real-life example. This is a photo I took a long time ago, but it's a woman crossing the street in Brookline, Massachusetts, and you can't see it very well, but on the picture on the left, it says 54 seconds. Now, I watched her wait for the light to change, so she probably had a little bit of cognitive slowing because it took her 6 seconds to initiate movement. And on the right panel, you see the right photo, you see that she gets across the street and it's about 14, 15 seconds left. And so it took her about 45, 46 seconds to cross the street. Now, the year after I took this photograph, they reduced the time to cross the street to 35 seconds. So now she's no longer able to navigate her neighborhood. She can no longer participate in her life role. And maybe she was walking across the pharmacy to the pharmacy, which is the CVS pharmacy, to get her medications that you as the primary care physician prescribed, or maybe she was getting some products at the body shop. But regardless, she's no longer able to function in her life role, no longer able to participate. And so one of the challenges that we were faced was there's no pill for managing this until the senolytics come along. But really the treatment was rehabilitation, and so the challenge was what was the content of care that we should focus on. And so we were faced with, if we looked at the literature, there was probably about a dozen different body system impairments that were identified as being important and relevant to mobility skills, and we didn't know which ones were most important. And the sort of example I give is that if I lined up 5 different physical therapists, I'd get 6 different opinions about which impairments to prioritize for this patient in care. So it really wasn't evidence-based, and so we wanted to address that. And we're going to talk a bit about that a little bit later on, but conceptually, the World Health Organization characterizes disablement by the International Classification of Functioning. And it talks about body functions and structures, which are, if you think about like strength, and if you have insufficient strength of the musculoskeletal system, you're weak. That's an impairment. If you're thinking of cardiovascular system, it might be reduced ejection fraction. And together, those will contribute to slow gait speed, which is defined as an activity, which is a generalized performance-based task or self-reported task that you can measure. That when insufficient is characterized as limitations, whereas when body systems are insufficient, they're characterized as impaired. And all of those contribute to a larger scale concept, which is participation in your life role, which when deficient is restricted. Now, they're influenced by comorbidity, environmental factors, and personal factors. And this was really a conceptual model that was developed, as I said, conceptually, but what I'm going to try to show you the next few minutes is that there's strong empiric evidence for each of these interrelationships. And I'm going to highlight some of the work we've done and some of the work that others have done as well. The other important thing that I want you to emphasize is that as we start on the left, and even left of body functions and structures, maybe a lot of the sort of laboratory science, basic cellular level biochemical mechanisms that are sort of driving what's going on with those systems. And so as you are way on the left side, it's very biologically driven. But as you move to the right, those outcomes are more socially and behaviorally driven. So much so that at this point, if you were trying to, when studies, if you look at the literature and you want to predict activities, performance, you find that only about 50% of the variance is described by biologic factors. It's also driven largely by behavioral and social factors as well. And so our interventions need to be reflective of that if we want to, depending on which outcome we want to influence. And so it may be that in the future, if we have senolytics that are really effective, it may be in combination with interventions that focus on behavior and also socially addressing the environment and so forth as well. That should advance. All right, so we did a study, as I told you, to address the challenge of this woman's fate here, and it was called the Boston Rehabilitative Impairment Study of the Elderly, and it was looking at primary care patients from 13 primary care groups within the Mass General Brigham and Women's healthcare system in Boston, and these were all older adults that were in the primary care clinics that were identified as being at risk for mobility decline over the following 2 years, much like the annual wellness visit would evaluate them. And what we did was we followed them over 2 years to sort of look at their functioning and look at changes in these impairments from these dozen or so impairments that were linked in the literature. And what we ended up finding was that there was really only 4 that were driving mobility decline from the group that we saw. It was combination of strength and speed, which actually is the ingredients of power. It was a combination, it was flexibility, and it was also trunk muscle endurance, which is not your absolute total strength of your trunk muscles, but it's sort of submaximal strength, being able to be sustained for a long period of time. Now, these are all attributes that we know are very important for athletic performance in sports, but they're also important for mobility performance and living independently. And others have done related work and recognized that timing and coordination of walking, of gait, are also some very important attributes that we didn't measure in our original study, but that are also important targets. And so in our work, we really target this subset of attributes because this is where the money is in terms of trying to treat people to improve their mobility and participation. Now, this is a paper that Marla did during her postdoctoral work, and so we wanted to look at the relationship between these activities and participation, and do we see these sort of interrelationships? And indeed, it was shown from looking at the same data set that the influence of trunk muscle endurance and range of motion on participation occurred, but it was actually acting through changes in advanced mobility activities. Now, leg speed had a direct relationship, but that may have had to do a little bit with the sorts of activities that we were looking at in that analysis and other factors as well. But it did bring out the fact that there is this sort of hierarchical relationship by which these things interact, these domains interact. Now, next, we also looked at comorbidity, which is a very important area in geriatric care. And there's a lot of influence and a lot of interest, I should say, in patterns of comorbidity. And so this is work done by another postdoctoral student, Minnie Jacob, who looked at the patterns of comorbidity in our data set within Boston Rise. And she developed latent classes and actually found 3 primary types of comorbidity patterns. One that we sort of called high comorbidity, another we called low, and another which was really more predominantly musculoskeletal comorbidity. Now, they existed within the data set, but they had no association with the disablement outcomes. However, when we looked at just the simple count of comorbid conditions, just the number, we saw that actually that was predictive of each of the disablement domains, and also not only cross-sectionally, but prospectively as well. So actually, it allowed us to really to simplify how we conceive comorbidity in these epidemiologic studies if we're studying disablement outcomes, where it's really just the overall burden rather than an actual pattern. But it also highlights the interrelationship between these concepts. And so now I want to talk a little bit about personal factors, and to do so, I want to describe another study that we did. This was published in JAMA, and it was a study of patients that had hip fracture. And so we looked at patients that had finished all of their rehab, had, in a sense, were done being treated after their hip fracture. And at that time, and even today, the outcomes of hip fracture are really pretty awful. It's a seminal event that predicts mortality and certainly disability as well. And so what we did for this study, the intervention was to actually have people engage with a physical therapist for 2 visits, but to receive an exercise program that was delivered by a DVD. And what they would do is embedded in that exercise program was actually a focus on behavior change. And so it was a combination of exercise and behavior change that was then employed. And so they would just participate in this on a regular basis for up to 6 months, again, with only 2 visits from a physical therapist. And the control group had a nutrition, were counseled with nutrition with a very similar number of visits, so we controlled for the amount of contact. And what we saw at the end of 6 months was that these people that allegedly plateaued had significant improvements in their mobility skills after being involved in this intervention. But the intervention stopped at 6 months, and we saw that those improvements were sustained at 9 months. So that was really great news. So not only did we improve function, but it was sustained, but then we also found that it was mediated by changes in self-efficacy, implying that the behavior change component was playing a role in creating those sustained improvements in functioning, an important ingredient that needed to be included. And so the last component that I want to talk about are the environmental factors. And this is work that was done by another investigator, Leanne Quach, who looked within Boston Rise at falls. And what she was interested in was the relationship between that was sort of established that not only was there a high fall rate in this population, but also there's a high level of cognitive impairment. And those with cognitive impairment had higher fall rates, which is pretty well established. But she was very interested in social engagement. And so she looked at social engagement in these individuals, and what she found was that social engagement really mitigated the impact of cognitive impairment and its influence on falls. So it was really highlighting the fact that those that were more socially engaged were at less of a risk for falls. Now that may have been because the spouse was looking out for them, their environment was modified, and other factors, but if you start to think about the impact of social isolation from COVID, you could imagine a number of different ways in which this interrelationship may have occurred, but it was an important relationship to highlight. And it's an area that we tend to not intervene upon. Now this is work done by a colleague at Brigham and Women's Hospital, a neurologist named Amar Don, who's very interested in work on social networks. He actually done a Rhodes Scholarship, and this is where he started to look at this, and he's applied this to rehabilitative care and actually stroke rehabilitation. And so he's looked at outcomes, and what he's found is that if you look at the size and density of an individual social network, it actually was strongly associated with outcomes for stroke rehabilitation, both if you look at it in terms of physical performance measures and self-reported measures. And he's also seen this strong relationship as well in patients with MS. So again, it's an opportunity, if we start to think about intervening as another level of intervention that may be opportune and may be influential in the long run. So that brings us to sort of how we think about delivering high quality care. And so in the United States, especially under the Obama administration, there was a big focus on healthcare. And there was an article, this was from Harvard Business School, that talked about what's value in healthcare. And it was defined as the health outcomes achieved that matter most to patients relative to the cost of achieving those outcomes. We heard a lot yesterday about personalized care and patient priorities care, and this really speaks to that. And again, I want to emphasize what I said in the beginning, is that maintaining functional independence is one of the major priorities of older individuals seeking care as well. So we need to think about those. And so what geriatrics has done is there's been a big focus on what's been called the age-friendly healthcare systems. This is a photo of Mary Tinetti, who's really a leader in this area. And the big focus in geriatrics is the recognition by my geriatric colleagues that there's never going to be enough geriatricians to care for all the older patients. So what they need to do is to train us non-geriatricians to think like a geriatrician. And so what they do is they focus on what's called the 4 M's. And so number 1 is what matters most to patients. Number 2 is what's called mentation, which really refers to the mind, cognition and mood. Mobility, which is physical functioning, and then the impact of medications. And so there's a huge emphasis now within VA care in particular to really implement the 4 M's across care at all levels within VA, and actually outside of VA as well. Now, if we think about that, and we think of it, if we put, those of us that are rehab providers, we put our rehab hats on, we'd say, well, we kind of think in that way too. You know, we'll think about what matters most to our patients, and tends to be physical functioning. That's what we're trained to address. We'll think about the impact of cognition, and we're actually trained to sort of also think about medications, though not to the same level that our geriatric colleagues are. But then also, as I highlighted, we're also thinking about motivation and behavior change. And so when I think about geriatric rehabilitation and the essence of geriatric rehabilitation, I sort of highlight the 5 M's, and I am definitely sort of stealing that from the geriatric colleagues at University of Ottawa, but we're putting motivation on there as the sort of 5th, the pinky of the M's. So let's think about how we're going to care for this older individual based on what we've talked about. Well, within VA, we wanted to look at, well, what's the prevalence of slow gait speed in our primary care clinics? Because that's sort of the screening tool that's used. And so we piloted this study. This is a clinical demonstration project. There's some data from that. And what we saw was that 25% of our primary care patients that were 65 years and older had gait speeds that were 0.8 meters per second or slower, which is considered a really high risk for adverse health outcomes. And actually almost 50% were 1 meter per second or slower as well. So it really depends on how big a net you want to cast, but 1 meter per second is still a meaningful risk. And so it just allows us to decide how many people we want to treat with whatever intervention we have. But it's clearly a need. And so this was an argument that we used to implement a care program that we've been working on with the administration. And the care program that we've been working on for the last decade or so is called Live Long, Walk Strong. And so what it's done is it's really taken the role of the physical therapist and say, if we take what are the best practices of a PT and we operationalize that in an evidence-based fashion and deliver care, that's what we call Live Long, Walk Strong. And so it involves focusing on those physiologic impairments that I talked about, having the physical therapist working as a coach and an agent of behavior change, and then also working as a case manager with a primary care team and with community-based programs to help engage that person in healthy behaviors long term. And so we piloted this with the clinical demonstration project at Spaulding Rehabilitation Hospital. In fact, we did this in over 400 individuals. This was a paper we published where the analysis was finished in 2016. We had almost over 350 individuals that were referred from primary care with mobility problems. Now, 40% of them could never engage with this outpatient care program because they couldn't get there. So that's a problem we're going to talk about in a little bit, reminiscent of what's happened with COVID. But we still had 60% of those people enrolled in the program, which is quite good considering they wouldn't receive any care otherwise. And actually, it turns out here, it shows 76%, 80% of those individuals fully completed the program. They finished all 10 to 12 sessions of physical therapy that were prescribed. And so what we saw, and this is shown in this figure, if you look vertically at the sort of grade bar vertical, that corresponds to a 1 unit difference when you're moving from left to right. And a 1 unit difference, this is the short physical performance battery, is considered a large clinically meaningful difference. And the overall mean improvement was about 1.7 units. So hooray, physical therapy worked. At the end of 12 weeks or 12 treatment sessions, we saw that we improved physical functioning. But the real question was, what about these factors that tend to mitigate the benefits of rehabilitative care, such as advanced age, fall history, manifestation of cognitive impairment or dementia, high levels of comorbidity, pain, or even their stage of exercise change, their willingness to engage in exercise and behavior change. And what we saw is that even when you accounted for those factors, there still were meaningful improvements in functioning. So these factors didn't necessarily mitigate the improvements of our program. So it seemed like we were on the right track with this program of care that we've been developing. Now, this is pre-pandemic. We wanted to address the individuals, those 40%. And so we did a study that was called REACH. It was Rehabilitation Enhancing Aging Through Connected Health. And what we did was, because the first program that we developed was fully reimbursable by Medicare. This is more innovative, and it wasn't reimbursed, so we had to do it in the context of a clinical trial, where we actually had 6 visits that were with a physical therapist that were provided to individuals, and it was up to them what they wanted to prioritize, whether they did that in an outpatient setting or they did that at home. But every individual was given an iPad tablet, and on that tablet was an app. And the app was really focused on helping them with their exercise program. So every day they'd get a reminder, have you done your exercises today? And then they could click into the exercises and would have a video of them doing their own exercises with the instructions being narrated by their physical therapist, so they could do those. They could characterize how it went. And there was a chat feature which allowed them to communicate back and forth with the physical therapist so the program could be modified or reinforcement could be provided. And so these 6 visits were spread out over a period of 6 months. And then they were allowed to continue with using the chat feature for another 3 months. And then we looked at outcomes at 1 year. Now, actually, let me just go back for a second. The control group was actually individuals that were matched that were from the longitudinal cohort study that I described before. So they were recruited the exact same way. These are older primary care patients from Mass General Brigham that are at risk for mobility decline over 2 years. And so when we looked at the exercise program, adherence to the exercise program, good was characterized as exercising twice a week, very good 3 times a week, excellent 4 times a week or more. And we saw that really as many as 92% or at the end of 9 months were engaging in exercise at least twice a week, and the majority, 63%, were doing that at the end of a year. Now, there is a drop-off when the contact ended at 9 months that you can see, but it still was showing that people were exercising, and even 2 times a week is really beneficial for people. Even 1 is, but 2 is definitely. When we looked at changes in functioning compared to we matched people based on weighted propensity scores to the people in the group. So we had the data set of 430 people to compare to the 75 that were in treatment. We saw that there was significant improvements in gait speed that surpassed a clinically meaningful difference, and same for the short physical performance battery at the end of 1 year. So it was improving functioning at the end of 1 year. And also, and we didn't really power our study to look at these outcomes, we saw a 73% reduction in emergency room visits too as a result of this program. So it was really functioning as a prevention program. In terms of hospitalizations, we weren't powered to do this. It wasn't statistically significant. I just want to show you the effect size was about a 22% reduction, just to give us a handle for future studies on sort of what we're thinking about, and so that we could design those studies in the future. But the effect size was in the right direction, so that was promising as well as a potential way of treating these patients. Now, since this work and since we implemented this in the VA, we've had to deal with the pandemic. And so what we've done is a couple different things. One is that we've adapted this program for the skilled nursing facility. And so one of our challenges, and that's called the CLC Center in VA speak, but it's the skilled nursing facility. So patients that are undergoing subacute rehab, one of the biggest challenges is you can improve functioning, though that's variable, but they usually fall off a cliff when they're discharged home. And so we've been adapting the program to help with that transition to home, to maintain contact, and to look at outcomes 3 months later. And we've also adapted the program to do it all virtually, for outpatients as well during the pandemic. And while we have publications being reviewed right now on both of these, I can just say that we were pleased with the outcomes and that these studies in terms of where you're seeing sort of similar kinds of findings, though albeit the sample sizes are small, they're really at the pilot phase. But this is work that we're doing in an ongoing way. And so if we were checking the boxes of the M's or thinking about the ICIF domains, you'll see that we're really checking each of those and that our treatments are designed to sort of address those domains in each case. And I think that may be a model for us to think about as we go forward in how we design our rehabilitative interventions in general, for people as they're aging, and also in particular during the pandemic. And with that, I'll conclude. Thank you very much.
All right. So it's great to be here today, and especially to be here with Jonathan, who was, yes, my postdoc mentor. And I think a lot of my grad students are laughing because they're seeing a lot of similarities in how we conceptualize things. So Jonathan started by talking about the importance of mobility and rehab and, physical function as a vital sign. And so now I'll talk to you about how that kind of applies when we look at COVID-19. So I'll talk to you about mobility after hospitalization for COVID-19, what mobility looks like in the community, where the majority of patients were not hospitalized, and then some implications for rehabilitation. So this was a meta-analysis that's probably been updated, has been updated since 2021, but I like it because it shows you all the different body systems that have been impacted by COVID-19. In this study, this was a meta-analysis, and they found about 80% of patients had one or more long-term symptoms after their COVID-19, and they documented 55 different effects of COVID. The most common in this meta-analysis, which did include sort of a mix of patients, were fatigue, headache, attention disorder, hair loss, and dyspnea. So what do we mean by post-COVID condition? And this has kind of been an area that is really a moving target. So the term post-COVID condition is sort of an umbrella term. It's been adopted by many major organizations, and it's meant to sort of encompass the wide range of different health effects that can be caused after COVID. So it includes things like new and persisting symptoms, the most common being fatigue, dyspnea, and brain fog, multi-organ effects of COVID-19, which have been documented in most, if not all, body systems. And then, of course, the effects of COVID-19 treatment or hospitalization itself. So patients with post-intensive care syndrome and post-traumatic stress disorder is also included here. So the World Health Organization, because of lack of consensus on what the definition of post-COVID was, and I should say post-COVID, also called long COVID, long haulers, or PASC, post-acute sequelae of SARS-CoV-2 infection, lots of different names. But they've basically released this case definition, and I kind of like it because it's the most comprehensive one that's out there. It says that post-COVID conditions occur in individuals with probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months and cannot be explained by an alternative diagnosis. They say the most common symptoms include fatigue, shortness of breath, and cognitive dysfunction, but also others, and that these symptoms have an impact on everyday functioning. They also acknowledge that symptoms can be new onset, they can persist, or they can fluctuate and relapse over time. So I think that definition really does a good job at reflecting the complexity of post-COVID and long COVID. So a lot of research has been done on symptoms and how long do symptoms persist, but a lot less research has been paid to looking at functional recovery and functional status. And as Jonathan pointed out in his talk, we know that functional status is an incredibly powerful predictor of health outcomes and is incredibly important to patients. So what does it look like after hospitalization for COVID-19? So early on in the pandemic, we started a longitudinal cohort study with 5 hospitals in Hamilton and Kitchener-Waterloo. And it was based on a registry project called Courage. And it's a registry that we started. I don't know if Andrew Costa's here, but he was the lead on this. And we started this registry very early in the pandemic in order to capture detailed medical information on all lab-confirmed COVID-19 cases. And we did this in collaboration with the WHO ISRIC platform. And it became clear to us really early on that besides capturing information on the acute phase of illness, that we needed to start looking at long-term effects. So we added this prospective cohort study extension to Courage. And so we recruited patients essentially on admission to the hospital ward, and they did a telephone interview on discharge, and then we had 3, 6, 9, and 12 months of follow-up. And we did that using a combination of phone interviews and home visits. We also, because we started in July 2020, we had missed some patients that had already been discharged, and so we could still go back and recruit those patients, and they entered the study at their closest possible follow-up. So this is just a list of all the different study measures and time points, and you can see we get information from a variety of sources, from the Courage Registry, from the phone interviews, and from the home visits. Today, given our focus on mobility, I'm going to focus on the AMPAC mobility scale, which was our primary outcome measure. And it's a measure I really like. It's called the Activity Measure for Post-Acute Care, and it measures patient-reported difficulty in doing 18 different tasks. And the really nice thing about it is it's designed specifically to look at mobility across transitions in care. So you can start looking in acute care, and it's completely relevant. Scores are then obtained for once patients are back at home and can be compared. And then the physical performance test that we had, Jonathan already talked about, short physical performance battery. So I'll just go through those results today. So the study's done recruiting. So these are the 282 people that are in the study. We had a mean age of 60 years, minimum 19, max 93. The majority of patients had well, no, not majority, sorry, 40% of patients had more than 3 comorbidities. And in terms of in-hospital characteristics, length of hospital stay was around 14 days, and with a lot of variability around that. Admission to the ICU was about 34%. So these are the symptoms that we collected on admission, discharge, on admission 3 months, 6 months, 9 months, and 12 months. And you can see on admission, which is that sort of first column, fatigue, dyspnea, and walking long distances were the most commonly endorsed symptoms. And so quite high, right? 78%, 73%, 70%. Then as we go to 12 months, I can't quite read it, when we go to 12 months, the same issues are also, the same symptoms are also endorsed, with fatigue reported by 48% of patients, dyspnea by 32%, and walking long distances by 38%. And so that's still quite a high load of deficits that we're seeing even at 12 months after resolution of COVID. So are these deficits, what's the impact on functional mobility? So focusing just on the first panel, because we'll just focus on mobility, you can see here this is results of a repeated measures ANOVA, and what you can see is that if we compare different time points for mobility, we can see that if we compare to premorbid status, so where patients were before they got sick, and we compare them to where they were at 3 months, 6 months, 9 months, and 12 months, they're significantly worse at all those time points. And then when we look at the data between 3 and 12 months follow-up, we're not seeing a whole lot of change. And then if we take this concept of clinically meaningful difference, so now we think how many people have a deficit compared to their baseline that exceeds what we know to be the minimal clinically important difference on this scale, we actually see that at 12 months, 57% of patients still have mobility deficits that are clinically important. The same applied for cognition and then daily activities as well, with slightly different numbers. So now if we go to physical performance and we look at results from the short physical performance battery, here we can see, if we remember that magic number of 10, you want to be, so scores of less than 10 indicate higher risk of mobility disability, and across the board, even by 12 months, you still have 65% of the sample reporting having physical function deficits that put them at high risk of a number of different adverse outcomes. So we also looked at factors that predict mobility recovery. And so just as a busy slide, I know, so if we just focus on the bottom regression model, we can see first that pre-morbid mobility, so what your functional status was before you got sick, that predicted most of your functional recovery at 12 months. And that's not surprising, but what's the unique thing that we actually have this data in the study, as a lot of studies don't have that data. So 65% of the variation in function at 12 months is explained by functional status before patients got sick. But also being male, being younger, having fewer comorbidities, and being hospitalized during the second wave of the pandemic also contributed to this model. And so this gives us a good sense, a preliminary sense. This is data based on just waves 1 and 2 of what some risk factors might be for development of these long-term outcomes. So what about non-hospitalized people that get COVID-19? So we had the opportunity to do this analysis in the Canadian Longitudinal Study on Aging because they completed a COVID survey. It was launched during the first wave of the pandemic. And we had data on over 24,000 people. And the really amazing thing about this is that because it was part of this population-based cohort study, we have a built-in comparison group, which a lot of studies don't have. So we had some physical function items from the first wave of follow-up in the CLSA, where patients are asked about difficulty standing up from a chair, walking 2 to 3 blocks, and climbing stairs. And we had that from the first follow-up of the CLSA, so that was conducted a couple of years before COVID hit. And then we have global rating of change in mobility question, and anyone that knows me knows I love these questions, but it just asks participants to rate their ability to move around in the home, their ability to engage in housework, ability to engage in physical activity, and they rate their difficulty level, their change in those things from much worse to much better on a 5-point scale. And what we found is that in individuals that had probable or confirmed COVID-19, and we did this based on definitions consistent with PHAC and the CDC at the time of data collection, these individuals had a twofold higher odds of worsening housework activity and physical activity. They also reported new difficulty standing up after sitting in a chair. And these results held even if we looked at the suspected COVID-19 cases. So these are people that would have been exposed to someone with COVID-19, had symptoms of COVID-19, but didn't necessarily receive a diagnosis. So these suspected COVID-19 participants had deficits in almost all of the mobility domains. And like I said, this is above and beyond background levels because our comparator group are people living in the community during the same time and subject to all the same public health restrictions. So what can we do about it? Well, good news is there's lots that we can do to help these patients. And we, the Canadian Thoracic Society, released a statement on best practices for rehabilitation for COVID-19 and some of the implications for pulmonary rehab. And most major health organizations now really endorse rehab as a strategy for these patients. And in all of the guidelines, an assessment at 6 to 8 weeks after the resolution of acute COVID is recommended. And in our guideline, we stated that all patients with COVID-19 should be assessed for persistent and new symptoms and functional limitations 6 to 8 weeks after their acute infection. And this includes people whose initial disease was mild. And then, because there was a big call for pulmonary rehab for these patients because of some of their symptoms of dyspnea, exercise intolerance, and cough, we had to have specific criteria around who would most benefit. And so people that should be referred to pulmonary rehab, they should really have respiratory symptoms, a need for supplemental oxygen, and some evidence of pulmonary impairment. And just some general considerations for rehab for these patients. The big thing is conservative progression and symptom monitoring, because these patients do experience what's called post-exertional malaise, which is a physical and mental activity-induced physical and mental fatigue. And so it's really important, especially we want to get them to buy in and to stay the course with our rehabilitation programs, that we don't push too hard and that we manage this as we go. The other thing is having education really specific to the challenges faced by people with COVID-19, so issues around fatigue, sleep and mood, cognitive problems, and return to work. And obviously a huge need for a multidisciplinary team. In terms of evidence for rehabilitation in these patients is emerging, but it's still limited, and there are issues with quality. But more is coming. So just to conclude, I hope I've shown you that I think COVID-19 has had a detrimental effect on mobility across the spectrum of illness. We need more investment in rehab to support our existing patients and patients that are dealing with post-COVID conditions. For example, pulmonary rehabilitation for people with chronic lung disease, access to pulmonary rehabilitation is only 2%. So if you think about then referring all your post-COVID patients to pulmonary rehabilitation, then your regular patients have nowhere to go. So we do need to ramp up these services. And then we also need to look into virtual programs and post-infectious disease care pathways, not just for COVID, but for other types of infectious diseases that impact older people, and figure out how we can also reach some of the vulnerable groups, the people that have been affected by COVID, because they may not be able to access rehabilitation in the usual way. So I just wanted to quickly acknowledge the teams that do this incredible work, like Andrew Costa, Mylin, Duong, Rebecca Kresselbrink, Terrence Hope, Harminder Rana, who were co-PIs on our functional recovery study, and all of our funders, patient partners, and the other expert panel members on the CTS guidance statement. Thank you very much.
Thank you, Jonathan and Marla. Great presentation. Now we would like to open up for some questions. We have 5 to 6 minutes, and so 2 or 3 questions, depending on how long the answers are.
Thank you very much for your talk. Both of them were very, very interesting. And I'm thinking about it in context of some of the things that came up yesterday, and how to reach some of the other populations that might not be participating in these studies. And are there strategies to try and make sure that these sorts of rehab interventions are available to a broader group of people?
Sure. I mean, one of the nice things about pulmonary rehabilitation is that it is a program that does already serve a marginalized population. So we have some strategies that we already know work, but I think definitely there's a lot that we need to figure out. A lot of these patients with COVID-19 don't speak English. A lot of them, there's a lot. I didn't get into the socio-demographic data that we have, but a lot of them are lower income as well. And so, we're starting a trial right now on a rehab trial for post-COVID patients. And one of the things we've had to do is, yes, we give tablets, but they have to be internet enabled, because we can't assume that these patients have internet. So those are some strategies. We probably need to do much more. And I think as more and more research emerges, we'll have a better idea. But I think it's a really great point, because I think it's risky that we develop programs that don't really accommodate the majority of people that are suffering.
Yeah, Within VA, the VA healthcare system is actually the largest healthcare system in the U.S., and they're responsible for the patients over the course of their life. And it's a very diverse population, and so that's why there's been a big focus. There was a big focus on telehealth long before the pandemic. It's just the pandemic accelerated that. So that's why we're really focusing a lot in terms of programs from that perspective. The other part of it is that as you get to the health services research level, it's really important to the notion of participatory research and research design in terms of getting interest groups from different populations, underrepresented populations, to sort of adapt what you're doing to their needs is really a critical piece. And we are fortunate that we have a very large health services research program at our center that we can collaborate with, but those are the sorts of efforts that we anticipate in the future to address those concerns.
Maybe I'll ask a question to Jonathan. You showed the slide deck where, as a picture you took of old lady crossing the crosswalk, and it was 45 seconds, and then a year later they had reduced it to 35 seconds to cross but in your thing, at least the way you presented data, it focused on the individual. Wouldn't it have been easier and affected a larger number of people if we would have worked with the city to keep it at 45 seconds, modifying the environment rather than just focusing on the individual?
Yeah, you're absolutely right. It didn't tell the story as well, so I didn't emphasize that as much. But that's a very important point, and it's why that photograph that I set up, I use it in every talk that I provide because it just keeps giving. It brings out so many aspects, and that's a really important piece of it all, is looking at the built environment and how we build it and how we adapt it. If any of you have been to Florida, where there's lots of old people, I can't imagine a place that's more poorly designed for older individuals. There's highways everywhere. There's very limited places to walk. Those that are walked are in sort of gated communities, et cetera, et cetera. So good point.
Thanks. Brenda.
Yeah, thanks for that comment. I think beyond the built environment, the attitudes, right, are also what lead to sort of some of the physical environment. I think this notion of rehabilitation as prevention, and both of you are messaging that, is such an important reframing, right? Because oftentimes we're coming in after the fact as rehabilitation professionals. So I just have a question about, I was looking at the BMI and then I had to Google, Marla, the BMI, like where the person are mean of your sample, and it's high, right? They were obese, so to speak, right, in terms of when we look at the BMI, and I know it wasn't by gender either, right? It was the mean across your sample. And I was just thinking about exercise in people's lives before even the pandemic, so to speak, right? And how we integrate exercise in our lives. Now, where's the question everybody's wondering right now? I guess I'm just thinking about, so then we're, introducing in some ways people to exercise. It's not that it was already a part of their lives. So to your point, Jonathan, about behavior change. And I just wondered, Marla, if you can comment on, like, even as part of the 3 more comorbidities, what was obesity one of them? Or, so it's not really a question, I guess.
Obesity was one of them, and definitely number of comorbidities did predict functional recovery at 12 months. But to me, I think that that's really helpful to know that. So if we know that functional status before you get sick predicts how well you recover from illness, that's something we can change. Right? So it shouldn't be that they're coming into the hospital and that's the first time they're doing rehab or engaging in physical activity. And so I love the idea of rehab as prevention also, and I think that that's what the data shows, is ultimately if you optimize people's health and build resilience before an event, you can mitigate some of the consequences down the line.
And I think I think rehab can play a very critical role But also, I think that sort of multifaceted approach where you're sort of looking at treatment at a biologic level, where it may be some pharmacologic treatment that's going to sort of impact things at the body system level, and then some of the exercise and behavior change at the higher levels, and that in combination is probably where we need to go. And so the challenge is how we frame it, and I think institutions like this and the outstanding work that's being done, you can be a leader in sort of helping that move along.
Last question. Go ahead.
Hi, great talk. Just on the kind of idea of behavior change and motivation that you talked to, I was just wondering if you could tell us about how you address motivation in your intervention. I know you mentioned the reminders on the app coming up. Motivation is quite a complex concept, and so I was wondering if you guys are addressing it in other ways.
Yeah, the primary approach that we use in Live Long, Walk Strong is the focus on a coaching model. And it's using what are called SMART goals, specific, measurable, and I forget what ART stands for. In the pressure of the moment, my behavioral health colleagues would be very upset. But at any rate, we've operationalized an approach to that, depending on, and it's just sort of modified based on the program of care, setting of care. But that's what it is, because at the end of the day, we wanted to make it tend to be very pragmatic. And what is it that a physical therapist can take on in the context of all the other things they have to do? And that was the approach we took.
Well, in the interest of time, we could go on and have more conversation. We will end here. Jonathan, you could have just said American Rehabilitation Therapies, and we would have believed you for ART. Anyways, thank you very much, and please join me in thanking Marla and Jonathan for their wonderful talk.